السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. أنا اسمي أنور جماح من جامعة الملك سعود بالرياض في المملكة العربية السعودية. يشرفني ويسعدني أن to join you. I'm going to talk about thyroid nodule today, and I have 20 minutes to finish, inshallah. I have nothing to disclose. And we'll start by the thyroid nodule. Thyroid nodule is a very common problem, which I think it's the second after the diabetes in the world of endocrinology. It's increased with age. It's more common in female, and malignant nodule is account for less than 5%, and autonomous nodule account between 5 to 10%. Why we care about thyroid nodule? The main thing is the risk of malignancy, and the second thing is the autonomous function, which is the toxic nodule. I'm not going to talk about thyroid cancer by itself, but it's also a common cancer, and the thyroid, malignant thyroid nodule was found. The postpartum case is around 6%. In some record is up to 11%. This is the old famous slide by Mazafiri talking about the thyroid nodule etiology and differential diagnosis. The thyroid cancer, as I mentioned, is a very common, and if you can see here, between age of 15 to 29 in Saudi population, the thyroid in female is number one cancer in form of incidence, and from age 30 to 44 is actually the second in female and in male. So it's a common cancer among young age. How we evaluate thyroid nodule, I think you all know about this. So we talk about history. So the history is the main thing, is the family history of thyroid cancer, the history of ionized radiation, especially in the childhood or adolescent. Age is a major factor also. Very young and very old have higher risk of cancer. Male sex or gender is also associated with higher risk of malignancy among thyroid nodule. Growing nodule by history is also carry a high risk. The other part of the history, we ask about the functionality. So we talk about hypo and hyperthyroid symptoms. And we talk also about the compression symptoms, including breathing and swallowing. This is in history. This is also important that when we talk about radiation exposure, and we learned from Chernobyl in 80s that exposure to ionized radiation is a risk factor for thyroid cancer, and this is only in the young age. So between infant life, to age of 19 is the major risk for thyroid cancer. So if the exposure happen between 0 to 19 years, that carry a significant risk. After 19, the risk is declined and almost equal to normal population. In the examination, we are looking for the cancer risk factor, including the firm and hard nodule, fixed nodule, and cervical lymphadenopathy. And also we look for functionality like hypo and hyperthyroid symptoms, and sign of compression, including inspection, percussion to look for the retrosternal goiter, and also we perform the Pemberton sign. The evaluation of thyroid by examination depends on where is this patient coming from. So from iodine depleted area, the volume of the thyroid is small, 10 to 20 gram, and it's very difficult to be felt. However, in the iodine deficient area, the normal thyroid reached up to 35 gram, and it's easy to palpate and sometimes easy to inspect or to see. The thyroid nodule that increase in size, it will be easier to be palpated, and 1 centimeter is the cutoff of palpation. What we do for investigation, we do the TSH, thyroid function test, the thyroid antibodies, and sometimes we do calcitonin. And this is the old evaluation of the thyroid nodule. If the TSH is low, then we think of thyrotoxicosis. We perform the scan rather than the ultrasound. And if there is a cold nodule, we do the ultrasound. If there is no cold nodule, we treat the patient as a toxic nodule if it's hot in the scan, and we'll go from there. If the TSH is normal or high, or if there is a cold nodule from the low TSH patient, the ultrasound is the next step of evaluation. Then we evaluate this patient for the need for a fine needle aspiration. The thyroid scintigraphy or uptake scan is important. So if there's a cold nodule in either technetium or iodine, that carry a risk of malignancy reach to up to 30%. However, the hot nodule in iodine uptake 131 or 124 or 123 is having a very low risk of malignancy. But we have to mention here that the hot nodule in technetium scan doesn't mean anything. It's actually the nodule carry the same risk of initially, which is the 5%. The other common finding is the CT detected thyroid nodule, and the risk of malignancy in that incidental finding is range between 0 to 11%. And one most important factor is the size. So if it's less than 1 centimeter, the risk is almost negligible and no need to further evaluate this patient. However, if the size is more than 1.5 centimeter, the risk is increased. And at that time, this patient needs a mandatory test, which is the ultrasound, which is the gold standard of evaluation, or radiological gold standard of evaluation of the thyroid nodule. The high risk feature in the CT scan include irregular or speculated margin, truncated calcification, inhomogeneous enhancement, or suspicious lymph node. And if there is high risk feature, or if the size is 1.5 centimeter, then this patient need to evaluate it more with ultrasound. The PET scan is also becoming a common finding, and if there is uptake in the thyroid, that increase the risk of malignancy to 35%, and this patient also required more evaluation by the ultrasound. So we come to the ultrasound of the thyroid nodule, and we believe that high resolution ultrasound is the most sensitive test to evaluate thyroid lesion, measure its dimension, and evaluate the cervical lymph node. The old ATA guidelines published in 2009, then it was updated up to 2015, showed high suspicious feature, which is the microcalcification, hypoechogenicity, irregular border, extrathyroidal extension, and so on. That is what we are doing for many years, and most of the endocrinologists believe it's important to evaluate the thyroid nodule by themselves. Then we have the Thyroid, American Thyroid, and they gave point for the composition, for echogenicity, for the shape, for the margin, and for calcification or echogenic foci. And depend on the point that they evaluate the patient to be thyroid number, and according to the thyroid number, we evaluate the nodule by fine needle aspiration and depend on the size of the nodule. I think most of us know this very well and working on that. One of the things that we also like to see, and it's mandatory to see in the thyroid ultrasound report, or when we are seeing the report itself, is the suspicious lymph node. And we here talk about the microcalcification, the cystic aspect, the peripheral vascularity, the hyperechogenicity, and the rounded shape thyroid nodule, extranodal extension. And the other thing also, which is important in thyroid nodule itself, the extension of the tumor to the muscle, or to the trachea, or to the nearby structure of the thyroid nodule. This is something that we may not see in the report, so we have to look at it ourselves. Sometimes they will give you the size of the nodule and they describe it, but they don't talk about the extrathyroidal extension. And this is from my experience, that sometimes it's missed in the report, and we have to look at it ourselves. So this is the old ATA, and they talk about the high suspicious nodule with the feature that we talk about, the irregular margin macrocalcification, taller than wider extrathyroidal extension, and they give estimated risk of malignancies in that old report is more than 70 to 90%. Then intermediate suspicion was dropped from 70 to 90% to 10 to 20%. Then low suspicious 5 to 10, then lower and lower. So in 88 2025, there's some change to try to fill the gap of the previous guidelines. And one of this gap is the unclassified thyroid nodule. They include more of the thyroid nodule that were not classified in the previous guidelines. They gave a thyroid ultrasound screening recommendation. So some people required screening, and they include it in the guidelines. And they eliminate the gap that we talk about between the intermediate, which was 10 to 20% to 70. So they actually decrease the risk of malignancy in the high risk group. Actually, they introduce also patient-centered approach and to the selection of thyroid nodule for fine needle aspiration. They discuss the follow-up of the benign nodule, and they outline the management approach of the intermediate indeterminate nodule, which is the 3 and this is the 4 cytology. So in 2025, the high suspicious nodule from the ultrasound, the risk of malignancy was decreased to 50%. Then the intermediate suspicious was increased to 20 to 15%, and based on the available evidence. The low suspicious 3 to 20%, and very low suspicious is than 3, and benign is than 1%. This is the recommendation for screening by ultrasound, and they suggest a screening of familial non-medullary thyroid cancer, and they define it by 3 or more first-degree relative had thyroid cancer. Then you start the screening, either start from 18 to 20 or 10 years younger than the earliest diagnosis. They are using the same criteria for breast cancer or colon cancer. The other screening, the Cowden or the B10 HTS diagnosis, also they recommend screening, and they did not recommend any further screening or any further group for screening. So the familial non-medullary, more than 3 relative have BTC, then they all the first degree family should be screened, and the Cowden diagnosis. The new guidelines talk about composition of the thyroid nodule, and they divided it to three, which is the solid. Solid mean it have to be more than 90% solid, and the cystic, and the cystic defined by more than 10% of cystic nodule is considered cystic nodule and cannot be a cyst. We'll go over it quickly, and if you can see here, the solid nodule is more than 90%, and when they talk about the feature, they talk about main four feature, which is irregular margin, the intrasolid punctated, which is the microcalcification, and they talk about taller than wider and microcalcification. The solid, they defined it to hypoechoic or markedly hypoechoic, and isoechoic. And here is the picture of hyperechoic, the isoechoic, the hypoechoic. They're talking about the microcalcification, the taller than wider, and this is wider than taller. They talk about the margin, if it's clear, defined margin, or unclear, undefined margin, or irregular margin. And they talk about the extrathyroidal extension or irregular margin here. And they defined here that the high suspicious, if you have markedly hypoechoic with one or more high risk feature, or hypoechoic with two high risk feature. The intermediate, the intermediate suspicion is markedly hypoechoic only with no risk feature or high risk feature. The hypoechoic with one high risk feature and isoechoic with one or more high risk feature is considered intermediate risk. Low suspicious is hypo, iso, or hyper with no risk feature of. And this table is just saying the same thing. The partially cystic is you have high suspicious when you are having high risk feature in the solid part, and low suspicious if there is only partially cystic with no risk feature. Cystic, as we mentioned, is you have partially cystic, you have spongiform, you have entirely cystic. The spongiform and entirely cystic is very low risk, as we know from before. And this is the example of the low risk cystic feature. The if you have one risk factor like macrocalcification or regular outer border, you have it low suspicious and very low suspicious if there is none. This is the non-classified, and they are talking about the egg shield. And if you can see here, the high suspicious, there is a peripheral calcification or protruding or breaking of the egg, that's mean high risk. The intermediate, if there is irregular peripheral calcification, and but there is no soft tissue like this one protruding, or low risk if it's complete egg and no breaking or no calcification or no protruding. This we talk about, and this is the range of malignancy and to consider the size of the nodule, and there is no big change. They consider 1 centimeter for the high risk, and they put a lower and upper cutoff. And this one is also added to the new guidelines when the patient is younger, is not like the older patients. So the threshold of fine needle aspiration will be lower if the patient is younger. If the patient have no comorbidity, the risk, the cutoff will be lower also. So we prefer not to do fine needle aspiration for elderly or comorbidity if no need for that. If there is a risk factor, of course, for thyroid cancer, that also lower the threshold. If there is evidence of sonographic pattern of risk of malignancy. Uh, the Also, if there is FDG positive, if there is symptoms attributed to the nodule, and if there is nodule localization. Um, the Thyroid also, we sometimes we still use the European, the Canadian, and it's okay to be used. For the final slide, I will suggest here. This is what I'm doing in my clinic, and I think most of the endocrinologists do. The first question we also ask also is ask first is this patient candidate for surgery? If he's not candidate for surgery, we should not go further for anything, no fine needle aspiration for this thyroid nodule. If the patient is surgically candidate and he's okay to go for surgery, the second question to ask is there is a lymph node, and if there is lymph node, this patient need to have fine needle aspiration, and from the lymph node and from the thyroid nodule. If there is no lymph node, the third question then is the extrathyroidal extension, and if there is extrathyroidal extension, we perform fine needle aspiration, even if the size of the nodule is small, or if there is a high risk feature or not. If there is no extrathyroidal extension, then we go to the size, and if there is less than 1 centimeter, we sometimes said, okay, we stop here. We don't do a fine needle aspiration of less than 1 centimeter. If there is more than 1 centimeter, then we apply the high risk factor like taller than wider, regular border, hypoechogenicity, microcalcification. And then if there is one of them, we perform fine needle aspiration. I would stop here, and I'm sure there will be a talk about Bethesda system. And thank you for listening, and sorry for taking longer time than I should.